So sorry about the change. You all know, I'm Vignesh. I'm a PGY4 here. So I just want to start off this talk by saying something that everyone probably already knows is that neurosurgery is the field of medicine that has undergone the most evolution since origin. But even within neurosurgery, different fields have undergone different, change during different eras. For example, endovascular right now is, for example, what Dr. Wang says, endovascular right now is going through what spine did, a decade or two ago with the innovation in materials, access and coils and stents, flow diverters. Endovascular is really in the middle of it right now. But really, though, I think evolution in spine, in some ways, I think is still in its infancy thanks to endoscopic surgery and all the possibilities it has to offer. So my goal by the end of this hour is to try to convince all of you guys that are listening that innovation in spine surgery is still at its earliest stages and it still has a long way to go. So this definitely is not going to be a talk on how to do endoscopic spine surgery. No one wants to UI4 sit up here and talk about actually how to do surgery. But what I want to do is talk about the new techniques and the indications and innovations that have occurred across the globe in this field, some of which have definitely been pushed to the edge, a little bit on the borderline of dangerous, but they haven't been replicated. Some of them really only have one case report, but still serve as an incredible launching for further innovation. So to do that, I'll just start a little bit about on the history of how we got to where we are, then go into the current new techniques and some of the new indications that endoscopy is being used for, and wrap up with the current state on endoscopic spine and what we can do to own this future ourselves. So just starting with a very brief history, I'm only going to talk about this for a few minutes. But endoscopic spine surgery really arose from two procedures. One was percutaneous surgery without direct visualization with radiographic targeting, and two was direct visualization without the ability to manipulate tissue. So simultaneous visualization and manipulation of tissue through a working channel eventually gave rise to endoscopic surgery. First reported visualization procedure using endoscopy was actually the esophagus in 1868. And the first endoscope with a working channel was the scope. So it had the components of the illumination, the optical lens, and a working channel used back in 1829. But within neurosurgery, the first endoscopic surgery was actually done by a urologist in 1910, and he used a rigid cystoscope to cauterize the choroid plexus in two infants with hydrocephalus. I talked about this last year, so I won't spend too much time on it again, but one of the first percutaneous spine procedures done by Lyman Smith in 1964, using chemonucleolysis, which was the enzymatic degradation of the nucleus pulposus of herniated discs. So what he did was he isolated the enzyme chymopapane from the latex of the papaya plant, which would hydrolyze proteoglycans and depolymerize the nucleus pulposus. And he injected this into disc herniations, which would compress the disc within. This was one of the x-rays from his original paper, and he did this at L4-5 and L5-S1. It was eventually actually FDA approved, but because it could non-invasively treat disc herniations, but almost injection could cause neural injury, meningitis, and hemorrhage. And so Hijikata, who was a Japanese spine surgeon, and you all know Barbara Kanbin from Philadelphia, refined this technique of percutaneous discectomy in the late 1970s and early 1980s. Kanbin did his first percutaneous discectomies under only local anesthesia and used fluoroscopy for localization, not endoscopy. So he was one of the first to describe a method to safely dock and work in the transforaminal region, giving rise to the Kanbin's triangle approach. In his method, he would start about 9 to 10 centimeters from the midline and pass the cannula parallel to the end plate into the dorsolateral disc, which he said would avoid injury to the exiting nerve root. This delineation marked a safe entry zone, marked a huge step forward in endoscopy, and this was because anatomically describing this safely drove the shift from percutaneous procedures to endoscopic procedures, because it allowed surgeons to be small needle-like instruments, larger instruments in the working corridor. So essentially that very briefly covers the percutaneous localization half of endoscopic spine surgery, but the visualization part started in 1931 with myeloscopy for direct spinal visualization. But this came with significant morbidity because you would inject this large bore scope through the dura into the thecal sac, which caused a lot of problems with infection and TSF leak. Also, these early scopes were bigger than the diameter of the spinal canal, meaning they couldn't visualize anything well, right? So eventually this was adapted to nucleoscopy or visualization of this phase. First fully functional, complete endoscopic system in the late 1990s. This was the first fully contained system of its kind. It had a 2.5 millimeter working channel, continuous fluid irrigation to maximize visualization, bleeding, and integrated video feedback. And the oval shape of the endoscope gave rise to a narrower cross-sectional footprint. The thing could be inserted down a 6 millimeter inner diameter cannula. And in 1996, this concept of biportal endoscopy was introduced. We had two separate incisions. An arthroscopic camera was passed through one, and instruments were passed through the others. More similar to laparoscopy and general surgery. The top figures are from the original paper. So originally it was described with two incisions cranial and caudal to each other to triangulate the camera and the instruments along the lateral edge of the lamina where it meets the facet. And you can see here the intraoperative in the intraoperative figure, the retractors are being used to displace the thecal sac to get access to space. And in some ways, biportal endoscopy helps to flatten the endoscopic learning curve when you compare it to uniportal endoscopy, because it's more similar to what surgeons are used to doing. Because when you have two incisions with the instruments in one hand and the scope in the other, you have the ability to move both independently from each other, and that's more familiar to most spine surgeons. So having an operative view separate from makes it more similar to the perspective of the X-scope or the microscope. And some studies have shown that biportal endoscopy can shorten operative time through decompression compared to uniportal endoscopy. However, it comes at a cost, right? Because biportal endoscopy doubles the amount of tissue disruption, doubles the the overall size of the incision. So moving on to techniques, going from old to new, and I'm going to split this up from lumbar to cervical to thoracic. So just starting with lumbar endoscopy. So Kaman's approach ultimately gave rise to lumbar transforaminal endoscopic. These can generally broadly be grouped into two types: the inside-out approach and the outside-in approach. The inside-out approach, the Young, just described a few slides ago, and then the outside-in approach was from Tom Huglen. Primary difference between the two is where the decompression started. With the inside-out approach, the tip of the working channel is along the posterior annulus of the disc anterior to the thecal sac, and the outside-in approach, the tip of the working channel is at the framing, posterior and lateral to the thecal sac. Over time, there have been many variations of these approaches, like the half and half approach, the mobile outside-in approach, but these two kind of served as the earliest foundation for the transforaminal approach. And with new instruments, this transforaminal approach could be combined with, for example, like partial removal of the pedicle, partial removal of the vertebral body to get adequate decompression. Three drawbacks to the transforaminal approach are that it can be difficult to access the L5-S1 level in patients with a high crest. It can be difficult to get good central decompression in patients with significant stenosis, and it's more difficult to treat migrated discs. The interlaminar approach can be used instead of the transforaminal approach at L5-S1 if the level can't be accessed because of the iliac crest. And here the endoscope is docked posterior to the ligamentum. And so because you're looking at the thecal sac from posteriorly, what you see is more similar to the view in open or MIS surgery, for example. The interlaminar space at 5-1 is the biggest one across all levels of the spine. It's about 30 millimeters, so you don't necessarily have to drill off any lamina to get access to the epidural space. And here, but to get to the thecal sac, you have to traverse the ligament. You can do this multiple ways. One is serial dilation in between the fibers of the ligament. Another is to split the ligament, and another is to use the Kerrison to exercise the ligament. But overall, the ones that are less invasive, like the like the ones with the splitting and the dilating techniques, overall have been shown to have less potential for epidural scar formation. But it comes at the cost of potential obstruction of your view because and of dural injury, because this isn't done under direct visualization. So the endoscopic unilateral laminotomy for bilateral decompression will BD approaches essentially what can be thought of almost like an ipsy contra with the endoscope. Here with the unilateral laminotomy, you get access to the bilateral epidural space. Gives you a posterior view of the thecal sac, like with the interlaminar approach. This approach is highly versatile. It can be used for central decompression, lateral recess decompression, foraminal decompression, as well as discectomy. You can see in the CT overlay on the bottom left. It can be used in the cervical, thoracic, and lumbar spine. Here in the top right shows the approach being used for bilateral central decompression. And panel B shows the ipsilateral laminotomy, and C shows the contralateral laminotomy going over the top of the contralateral ligament. And in E, you can see the finished vestibular sac. On the bottom right shows this being used for a contralateral foraminotomy. So after a midline laminotomy is done, the contralateral lamina is drilled out to remove the lateral recess. Then the contralateral foramen is decompressed by undercutting underneath the medial facet. Endoscopy has an extremely small footprint and very minimal tissue disruption. And this completely changes the way that a lot of spine pathology can be treated. Like take, for example, with degenerative spondylolisthesis, with stenosis that causes radiculopathy, but doesn't cause back pain. So even with traditional MIS approaches for decompression, you get some degree of facet disruption, which could eventually lead to infertility. And so because of this, you may need to fuse the level at the initial time of the laminectomy. That's where, some things like, the ULBD approach can offer a different option, because the endoscopic ULBD, you can get good decompression with minimal facet removal. For example, in this paper, group 1 patients had post-spondylolisthesis. Group 2 patients with the orange box had spondylolisthesis. And in both groups, the ULBD removed about 15% of the ipsilateral facet and 10% of the contralateral. So this was identical between the two. 12 months and 24 months post-op, the two groups were equivalent. It had a slip percent about 1 to 1.5% more than pre-op, which is the same in both groups, the ones with and without spondylolisthesis. So this shows that even in patients with pre-op spondylolisthesis, maximal preservation of the normal anatomy with the endoscope means that you don't necessarily get any worsening in stability, at least radiographically. So the extraforaminal and far lateral disc herniations are approached a little bit differently with the endoscope, given the location of the disc lateral to the foramen. So typically, for angle of approach to dock lateral to the facet along the lateral disc. In some ways, this is similar to like microscopic tubular surgery for far left. And endoscopy has played a larger and larger role in lumbar interbody fusion as well. So it's been adapted to the transforaminal, anterior to psoas, and lateral interbody fusion techniques. Transforaminal interbody fusion can be done either with preservation or a section of the facet. Facet sparing approach goes through a smaller access corridor, means you typically have to use an expandable cage to keep the space height. The transforaminal approach with facet resection can be done either with uniportal or biportal endoscopy, and it's similar to the approach with the tubular TLIF. We resect the facet-free access corridor. The endoscopic transforaminal TLIF is a good option for patients will benefit from indirect decompression of the foraminal stenosis, where expansion of this disc space creates ligamentataxis and increased foraminal height and unbuckling of the ligament to treat both centrally and foraminally. And on top of the indirect decompression, you can also get some direct decompression with decompression of the foramen and the ipsilateral central canal with the approach as well. Endoscopy can also be used as an adjunct to the ATP approach in patients who, in a select group of patients. 1, those who need interbody fusion, right? 2, those that have a ruptured or migrated disc, you can't necessarily get through the transforaminal approach. 3 is people that would benefit from having a larger interbody, and 4 is someone have all of this done in a stage position. So this is first done. It's not true full endoscopic, but it's first done by disc prep. And after this, you can introduce the endoscope into the disc space to explore and retrieve any ruptured disc fragments. The endoscope can also be used to cut the PLL and explore the dural surface fragments, which is hard to see, without with just direct visualization. Several studies have also published on endoscopy and lateral interbody fusion. One study took almost a laparoscopic approach. So they first used a single 1 centimeter incision along the lateral abdomen at the level of the disc space and put a trocar into the retroperitoneal space. Once they were in the retroperitoneal space, they introduced the endoscope and passed it to the lateral surface of the psoas muscle under direct visualization. And then they inflated the retroperitoneal space with a 1 liter dissection balloon. And after this, they made 2 additional 1 centimeter incisions as shown in the picture here. So now totally they had 3 incisions. With the original lateral incision, they used it as a working channel to pass instruments. With a second incision, they passed the laparoscope for visualization, and through the third incision, they used a retractor to retract the psoas anteriorly, as you can see on the right. So after this, using the working channel, they incised into the disc space, finished their discectomy, and then passed a standalone interbody. So now turning to the cervical spine, the 4 most well-established cervical endoscopic techniques are the posterior endoscopic foraminotomy, posterior endoscopic discectomy, cervical ULBD, and anterior cervical discectomy. Posterior cervical foraminotomy was first described by Rutten in 2006. This involves drilling through the medial facet and through the inferior IAP and superior SAP to decompress the foramen. These pictures are from his original paper. And the endoscopic approach for this has a significant advantage over open or MIS approaches because it involves minimal muscle dissection because the approach is done through sequential dilation and the overall cannula size is very small. And you also avoid subperiosteal stripping open or mini open approach, which can cause pain and disrupt normal anatomy and lead to post-surgical kyphosis in some patients. The posterior cervical foraminotomy and discectomy is a modification of the foraminotomy alone, which was also described by Rutten in 2008. After the foraminotomy is done, he would transverse the epidural space inferior to the exiting nerve root and lateral to the thecal sac to perform a discectomy of the protruding disc fragment. And studies that compared this to open surgery showed it preserved cervical motion to a greater extent than posterior approaches. Sometimes a foraminotomy and discectomy alone isn't enough to achieve adequate decompression, especially along the lateral and anterior aspects of the foramen. And so the foraminotomy and discectomy combined with a partial pediculotomy and vertebrectomy was described by Kim in 2020. So this involves drilling the medial aspect of the pedicle, vertebral body next to the exit foramen, which gives you more bony decompression, allows for all while preserving the facet joint. The cervical ULBD follows a similar approach to the lumbar spine for almost ipsy-contra decompression through unilateral laminotomy. Of course, unlike in the lumbar spine, you can't retract as much along the dura, which means you have to resect the contralateral lamina ligament. To resect the contralateral lamina ligament, which means you have to more aggressively undercut the spinous process to actually reach the opposite side. In multiple case reports, the cervical ULBD has been effective in treating cases of even severe posterior cervical, stenosis causing cervical myelopathy. Myelopathy was once thought to be a contraindication to endoscopic cervical spine surgery, but both the development of larger endoscopes and use of biportal endoscopy has enabled the use of endoscopy for myelopathy. The picture on the left shows the steps of the ipsilateral drilling, and the picture on the right shows the steps of contralateral drilling. This has been described both with uniportal and biportal endoscopy. So expanding on the methodology of the ULBD, biportal endoscopy was previously used once to do 2-level posterior cervical laminectomy with lateral mass instrumentation. So the incisions from the viewing portal and working portal were made both on the same side. The base of the spinous processes were cut to reach across to the contralateral side to expose the starting points for the lateral mass screws. Then they put the lateral mass screws in percutaneously, as shown in the top here. Then after this, unilateral laminotomy was done for bilateral decompression, like you can see in the bottom. So this was taken a little bit further with using biportal endoscopy to do fully endoscopic, a 2-level open door laminoplasty. So the first step was to drill the gutter along the closed door side of the laminoplasty. Then they put in 2 laminoplasty screws on each level of the closed door side, one in the lateral mass and one in the lamina. Then they shifted over to the open door side, and they used a full thick. They endoscopically drilled a full thickness gutter between the lamina and the lateral mass. They drilled off the tips of the spinous processes. Then they went back to the closed door side, and they passed a suture between those lateral mass and the lamina screws, and then tightened the suture to draw the screws closer together and essentially open the laminoplasty up. These have been done percutaneously since almost the 1990s, but in the 2000s they started to be done endoscopically. The endoscopic intracervical discectomy has been primarily to treat patients with soft disc herniations, mostly in central and paracentral locations. But a huge drawback to the endoscopic intracervical discectomy is the close proximity of important soft tissue structures to the access corridor. This method relies on about like a 5 mm incision made by palpating the junction between the carotid sheath and the trachea, followed by blunt dissection and blunt insertion of the dilator into the disc space, which of course puts at risk the carotid, the trachea, the esophagus. This risk has continued to hinder its adaptation and implementation. And after the cannula is moved to the posterior annulus, they would remove disc material with pituitary semicaricis. And while it's shown to be relatively effective in taking out the herniated disc, the endoscopic intracervical discectomy has been shown to cause delayed loss of disc height, likely because the transannular approach to the discectomy introduces a new anterior annular tear in a patient that already has a posterior tear, which causes disc material to extrude. So apart from the danger of this approach, the two main downsides of the endoscopic anterior cervical discectomy are, one, like you mentioned, the loss of disc space height, and then two, that disc fragments that migrate cranially or caudally can't be reached. And so the anterior cervical transcorporeal discectomy, in which the endoscope is passed through the vertebral body, can overcome both of these issues technically. The approach is done in a similar way with blunt dissection and introduction of the introducer, but once on the surface of the anterior vertebral body, a sharp stylet is passed through the vertebral body to the posterior wall. Then the PLL is divided and the disc fragment is removed. One concern is that the end plate adjacent to the bony entry channel will collapse over time, but studies showed that anything smaller than about 6 mm wouldn't put the vertebral body at risk. And here you can see in B and C on the right, the cross section of what the channel looks like. A few studies have described an endoscope-assisted ACDF. This involved putting a 2 cm tubular retractor into the anterior surface of the spine at the level of the disc space. And then after the disc space is done, with an endoscope for visualization, they would use a standalone cage and just leave it in the disc space. They reported solid fusion at 1 year post-op, but this still has a long way to go. Endoscopy has also been used to treat a type 2 odontoid fracture with an odontoid screw. And the approach is similar to an open approach, 3 to 4 cm incision and blunt dissection down to the C2-3 disc space. And then after the endoscope is introduced, they would drill the inferior corner of the C2 body, and then they would introduce this partially threaded odontoid, as you can see in the bottom here, to capture that fragment. So now moving to the thoracic spine. Endoscopy in the thoracic spine has developed more slowly than in the cervical spine for 2 reasons. One is the relatively lower incidence of thoracic pathology and degenerative disease, and 2 is the presence of neighboring anatomy making thoracic endoscopic access more difficult. So the ribs and the prominent TPs make it really difficult to access the foraminal region and lungs, and the aorta, and the IVC anterior to the rib head. Something to watch out for. But the most common approaches to the thoracic spine described in the literature are the transforaminal approach, the thoracic ULBD, the extraforaminal approach, and the thoracic retropleural. So the transforaminal approach in the thoracic spine was really popularized in the early 2010s, and it's most commonly used for soft disc herniations. Here the view is exposing the foramen to remove a paracentral and foraminal herniated disc. In the thoracic, unilateral laminotomy for bilateral decompression approach is similar to the cervical and lumbar spine. So central stenosis, ossified ligament, sepsis, and migrated disc herniations can all be treated with this approach. The thoracic ULBD has seen somewhat more rapid development in Asia because of the presence of ossified ligament in this patient population. And because the thecal sac in the thoracic spine can't be retracted, difficult to look around the thecal sac because of the ribs and the lung laterally. So getting good decompression might rely on a combination of different techniques. So Shen reported on a patient with circumferential compression from a ventral disc osteophyte complex and posterolateral facet hypertrophy ligament, which are the MRI. And he treated this with 360-degree thoracic decompression with both transforaminal and interlaminar methods, which with pretty good results. Here you can see the transforaminal decompression on the top, followed by the posterior ULBD. The technology has also evolved to deal with the limitations of thoracic anatomy. So this paper described an endoscope-assisted transpedicular decompression for a thoracic disc herniation. So after the pedicle and lateral disc were removed with an MIS tubular approach, they put in a 70-degree angled endoscope and a 90-degree curved like suction and instruments to look around the ventral surface of the cord to remove anterior disc and osteophyte that they couldn't visualize with just the, directly with the microscope alone. So you can see some of the intraoperative. Some of the real power of the spinal endoscopy really comes from applying it to new indications that you can use to do surgery either better or faster in patients that you wouldn't otherwise necessarily be able to operate on. Right, and endoscopy has been used both for decompression and resection of facets. The advantage of endoscopy is that it's only slightly an IR CT guided percutaneous aspiration of these cysts. So the access type can be chosen depending on the location of the cyst, with the interlaminar approach more done for cysts in the spinal canal and the transfemoral approach being done for both laminar region. But one caution with this is that, as you all know, synovial cysts can be very adherent to the dura. So care has to be really taken when detaching the cyst and it can be done piecemeal if needed. Sometimes the borders of the cyst can be difficult to distinguish from the dura and other soft tissue, especially under the magnification of endoscopy. So one study actually injected the cyst preoperatively with indigo carmine and a radio-opaque contrast before inserting the endoscope, so they could see it both under direct visualization of the endoscope and with fluoroscopy to help. Endoscopy has begun to play a role in the treatment of mild spinal deformity as well. There are two, example cases. In the first patient, the coronal Cobb angle measured about 30 degrees and the lumbar lordosis -16. Second patient, the coronal Cobb angle was again 30 degrees and the lumbar lordosis was 12. In both cases, disc prep and TLIFs were done fully endoscopically and all instrumentation was placed percutaneously. You can see the coronal correction is decent here, but there's several limitations to this. First, there's a little bit of restoration of lumbar lordosis, but in both cases, the spine is still, pretty straight. Also, the lowest level here, that they went to L5 wasn't the ilium. So this brings up the question of how much deformity correction and endoscope can achieve, right? Because deformity correction requires some degree of osteotomies, release of interspinous ligaments, or disc space correction. So the future, I think, of endoscopic deformity correction will rely on trying to find ways to mimic what's done in open or minimally invasive approaches. So this is a few years ago with, I think, Roberto as a lead author, looking at the feasibility of ALL sectioning through an endoscopic approach. An important factor to take into consideration is where the great vessels are and the level of the bifurcation, because it's important choosing what the side of the approach is and where the ALL has to be incised. This was done in a cadaver model, but applying it to deformity correction in patients will be an option for hopefully correcting sagittal imbalance a little bit better than the figure showed. So there are many applications of endoscopy in spine infections. Especially useful as an alternative to open surgery in certain patients. So one is in patients that who have serious comorbidities who otherwise wouldn't be able to tolerate surgery, who is an early intervention in developing infections when open surgery wouldn't be indicated yet. Another one is instead of a IR CT guided biopsy to both find the source, find the pathogen, and irrigate and debride the infectious source. While the rate of pathogen identification in CT-guided biopsies typically, is variable between 30 and 90%. Endoscopic techniques are shown to be consistently above 90%. So in that way, this, endoscopic surgery serves as kind of a middle ground without the invasion of open surgery, but a little more efficacious in treatment than a CT-guided biopsy. Like a fibrous burnt out infection in phlegmon may be difficult to drain just with needle drainage alone, but endoscopic debridement can help agitate and drain the infection collections. So the pictures here are from a case of osteodiscitis at L5S1. Visualization can be hard, it can be blurry with, because of the purulent material, but with irrigation, that may be homework. Endoscopy can play a role in spine trauma too. This is the case of a 33-year-old who came in after a fall with an L2 burst fracture. So first, the authors tried to treat the retropulsion with percutaneous instrumentation of ligament ataxis, but even with this, there was still a bony fragment of the posterior L2 body in the spinal canal. So instead of going back in and trying to work around the instrumentation, they used an endoscopic transforaminal decompression to drill this fragment and remove it piecemeal until the thecal sac and the nerve root they could see were decompressed. So endoscopy has begun to have been used with both extradural and intradural tumors. This is a patient who initially presented with a T6 tumor in the vertebral body, entered a thecal sac. He had a T4 to T7 laminectomy and costal transversectomy and had radiation, but ultimately ended up developing recurrence with numbness but no weakness. The MRI showed, as you can see here on the top left, recurrent tumor causing thoracic cord compression. And given that she was symptomatic, decompression was done through a transforaminal approach through the left T5-6 foramen. And they drilled out the they reamed out the ventral T6 SAP and the superior edge of the T6 pedicle to get more access to the foramen. They then gently elevated the thecal sac and used graspers to remove the tumor. These are a few cases describing the use of bipolar endoscopy and a ULBD approach to treat extradural tumors. So the case on the left shows an en bloc resection of an extradural hemangioma posterior to the cord. And in the case on the right, the patient had this aneurysmal bone cyst, which they didn't, find the pathology until after the resection. But aneurysmal bone cyst arising from the posterior vertebral body. This was partially resected, and the component within the spinal canal was decompressed. Again, they didn't really touch the portion within the vertebral body, but they got some decompression through of this extradural mass through endoscopy alone. There have been a few case reports on intradural tumors treated with endoscopy. So this patient had a T6 intradural extramedullary tumor posterior to the cord. They used the DeStandau's endoscopic system, which you can see here in B, with a 1.5 centimeter paraspinal incision to do a thoracic ULBD at the level of the tumor. Then they opened the dura under endoscopic visualization, and the edges of the tumor were delineated and was moved teaspoon. This was done entirely under endoscopy. Downside was that they closed the dura only by just putting a dural substitute over the dural defect and tucking it under the bony edges. So understandably, one patient developed a pseudomeningocele, but they didn't report any cases of overt CSF leak. You see the small CSF leak here. Endoscopy has even been used for intradural untethering and phylum sectioning. Here, the endoscope was docked posteriorly and a unilateral laminectomy was done with the endoscopic drill. They took the endoscope out then, and then the drill was opened under the microscope. Then they put the endoscope back in intradurally, shown here, and they identified the phylum with the endoscope. And then after it was stimulated, they took the endoscope back out and sectioned it with the microscope. So not completely done endoscopically, but at least 50% of the case. And one of the most important and convenient uses of endoscopic surgery is revision surgery as a way to avoid working through scar tissue from previous surgery. So this patient previously had an L4 to S1 MIS TLIF and subsequently developed heterotopic ossification around the cage, with causing stenosis at the right L4-5 foramen with radiculopathy. And instead of dissecting through all that scar tissue and risk of dural tear or nerve root injury, the endoscope was used for a foraminotomy to drill out the ossified area to expand the frame. So finally, just to wrap up, going to the current state of endoscopic spine surgery, its advantages and disadvantages, and how these disadvantages can be overcome to broaden some of the use of endoscopy. So starting with the advantages, there are several advantages. One, the patient, two, the anatomy, and three, the healthcare system, right? So the advantages of the patient are less anesthesia, less blood loss, less pain, a shorter hospital stay, an earlier return to function. Advantages of the anatomy are you have smaller incisions along the skin and the fascia, you have less soft tissue dissection, less retraction, which preserves anatomy to a greater degree and reduces the risk of osteogenic instability or delayed deformity, also causes less epidural scarring. And the advantages of the hospital system are that it can be done in an outpatient setting. It doesn't require all of the equipment that comes with general anesthesia, and overall costs less than MIS or open spine surgery. But endoscopy still has a long way to go before it becomes more commonplace in at least the American spine landscape. There are several barriers to this that may inhibit the growth of endoscopy. First, it has a very steep learning curve and typically requires at least some level of separate dedicated training before it can be done independently just for comfort. And so flattening the learning curve can help, theoretically broaden the use of endoscopy. And then, tackling the specific aspects of endoscopy that make it difficult, that make that learning curve so steep, can help overcome this. In addition, endoscopy has very high capital equipment cost, and thus, understandably, it receives less attention from device manufacturers. Companies are more likely to make a procedure that has a larger recurring costs, like, for example, deformity correction with loss of interpretation, than they would on a procedure that has a very high upfront capital cost and lower recurring costs. There are also some challenges to the billing and the reimbursement that I'll get into. Starting with waste of learning. There have been several attempts to introduce navigation to endoscopic surgery, and is something that, if used correctly, can make endoscopy easier. So, as you all know, navigation provides accurate, real-time anatomic guidance that enhances technical precision, right? And it has the obvious advantage over fluoroscopy in that it decreases radiation exposure and provides constant real-time feedback. Also, navigation can be used to calculate the optimal trajectory of the endoscope, which can be combined with the pre-op MRI to find the best angle that avoids bony structures in the DRG. In addition, navigation can be used for incision planning, which is critical in endoscopy given the small incision size, and a misplaced incision can cause a drastic injury. Because navigation can be used to confirm the location of the tip of the endoscope, it can be used, for example, during the disc prep or a T-lift, make sure enough disc is removed, to make sure decompression is adequate enough, or to avoid excessive bone drilling once the decompression is already done. So, on the other hand, to make sure you don't get too carried away with the bone drill. Also, the ability to view axial projections with navigation instead of just this vaginal anatomy and fluoroscopy has the advantage of making anatomy a little bit easier to understand. Navigation with optical tracers can be a little bit bulky, unwieldy in endoscopic spine surgery, and can interfere with holding the endoscope. But EM, electromagnetic navigation, is used instead of this. Navigation, robotics, and augmented reality are also all useful because they help understand where you are in the space, in this potential space when blood, bone, dust, or soft tissue get in the way of your line of sight, or when prior surgery and scar tissue make the anatomy confusing. Robotic assisted endoscopic spine surgery has the advantage of having a predefined trajectory with the robot arm giving you physical guidance. I think this is a paper from Roberto with senior author again, Wang. And so this means that not only do you have a precise image guided trajectory, but you also have you keep this trajectory exactly the same throughout the whole case to prevent deviation. And so because this trajectory is fixed, you can devote more attention to actually handling and manipulating instruments instead of worrying about maintaining your trajectory, which gives you more manual dexterity and control. I think these are two papers, I think one from Arya and the other from Timmer, both with Wang as well. And so augmented reality has the benefit of over navigation robotics because it gives you simultaneous visualization of both the navigation data and anatomical projections superposed on the optical field. So this is especially helpful in minimally invasive approaches, spine-like endoscopy, because you can't see any anatomic landmarks like you can in open surgery. So the artificially generated anatomic overlay, you get the relative location of the instruments, instead of just looking at the screen. So also a heads-up display with navigation or imaging data can be pretty useful, as you can see on the right, because there are a lot of things that require your attention in the OR. You have to keep an eye on the patient, the Mayo stand, the endoscope screen, the DR monitor, the navigation monitor. All of this can be very disorienting, make hand-eye coordination difficult. But the heads-up display of AR projects navigation data and surgical anatomy right into your line of sight. How of all of this navigation, robotics, augmented reality is that you have to make more incisions to install the parts, right? Something else that makes understanding anatomy in endoscopy difficult is that intra-op anatomy is projected 2D representation on the screen, and open surgery and microscopy both have stereoscopic imaging, which means that when they're viewed by both eyes, they're seen in 3D. The standard display of most conventional endoscopes is in 2D. So 3D endoscopic cameras and screens can give you millimeter perspective. There are 3D endoscopes on the there are 3D exoscopes on the market that have been customized for use in endoscopy, and you wear 3D glasses for the full effect. Resolution can also make identifying structures a little more difficult. 4K high resolution can help to more clearly delineate the anatomy, but one disadvantage of ultra resolution is that sometimes you can get imaging artifact with water turbulence while you're drilling, or with vibration of the instrument. Artificial intelligence is also going to play a larger and larger role in all types of surgery, and I think they'll have a bigger role in endoscopy too. So these images are from a paper that used AI for image analysis and laparoscopic cholecystectomy. On the left, the author authors taught the model how to identify certain structures like the liver in green, for example. The gallbladder was in red and the metacystic triangle is in purple. And on the right is an AI generated model for the target zone. So they, this program itself, came up with essentially what the access corridor should be just based on the imaging. This can be, pretty powerful in identifying structures. Anatomy is more complex and can tell you exactly how much, bony decompression you need by delineating all of this. Now, so those are all some ways to flatten the learning curve, but now looking at costs. So the only way to justify a high capital equipment cost is to demonstrate an overall cost savings in the long run. There's, unfortunately no other way to do it. This is a paper from back in 2018 demonstrating a $3,000 cost savings for about 15% for the total cost of the acute care hospitalization with the endoscopic compared to the MIST lift. And the cost of the endoscopic system is around, it varies, but it's around $500,000, depending on if the tower is bought separately or, whatever. This means the break-even point is about 170 surgeries, meaning that anything after technically makes the hospital money. And as the use of endoscopy increases, industry puts more and more time and money into innovation as well. So as with any other field, improvement in instrumentation is just a natural part of evolution. Innovation in instrumentation, whether it's cameras, drills, shavers, irrigators, help to overcome some of the hurdles in endoscopic surgery. It'll take a while to go over all of the advances in instrumentation in the depth that I should, but I'll just briefly go over two of them here. So one challenge in uniporal endoscopic spine surgery is that the instruments in the working channel can really only move in one direction if the whole system is in one place, right? You move forward and backward, moving laterally or superiorly, inferiorly. Require movement of the entire system. But this mobile burr head is able to move in three directions independent of the endoscope, which allows for less manipulation of the whole system and more degrees of freedom of the instrument. Another leap forward has been with expandable interbodies. So as you know by now, endoscopic surgery relies on making the smallest footprint possible, which is in direct opposition to the principle of using an interbody with larger cross-sectional area to promote fusion. So this is where the technology of expandable comes into play. The goal is to have an interbody that can expand to the largest cross-sectional footprint through the smallest diameter tube. finally moving to reimbursement. So the CPT T code 0275T was introduced back in 2012, and it represented percutaneous posterior lumbar decompression that didn't involve direct visualization of surgical anatomy with the naked eye. But the problem was this code wasn't covered by nearly all insurance payers in the United States, including Medicare and Medicaid initially. In 2017, the 62380 code was introduced specifically for endoscopic discectomy, but again, almost universally it wasn't covered. So the way around this really lies in advocacy. So there were two societies formed dedicated to endoscopic spine surgery in 2016. One was the World Endoscopic Spine Society, and the was the International Society for sorry. In the last several years, every major spine, neurosurgery, and orthopedic organization, including the AANS, DNS, ISS, NAS, ESMIS, AAOS, all have had sections dedicated to spinal endoscopy at their annual meetings. So just in conclusion, so new techniques, they're going to continue to grow the applications, the indications that endoscopy can be used for. Growth in the field will be driven by innovation in the tools used, and technologies to flatten the learning curve will increase the ability and drive its usage. And the primary way to incentivize endoscopy is going to be to increase its reimbursement. That's all I have. Thanks.
So the first case we'll have Sumed do. So this is a 42-year-old male who was diagnosed with this lesion about 10 years ago and underwent a VP shunt and intracystic catheter placement at an outside hospital. So now he's presenting to us with worsening vision in his right eye and weakness in his left hemibody. And on exam, his right pupil is 6 millimeters non-reactive, left pupil is 2 millimeters, and he has a right monocular temporal hemianopsia in left upper and left lower extremity at 4 out of 5. And so this is the CT that they got. Sumed, can you describe what you see? Is Sumed there? Okay, so I guess is Victor? Or I guess Turkey.
Hey, Eva. Yeah, so the CT shows non-con well, I wouldn't say isotypo dense cystic lesion at the mesial temporal lobe that extends to the prepontine cistern. I can see also two catheters, one a VP shunt and the other looks like it's in the cyst itself.
And then there's a CT scan. This is the MRI. Can you say, what sequences this are and what you see?
Yeah. So MRI shows it's a T2 in the upper left, and then we have T1 without GAD, and then the lower images are T1 with GAD. So the cyst is hyperintense on T2 and is hyperintense on T1 without GAD as well. So and also even with contrast, it's there's some enhancement at the periphery of the cystic wall. Seems like the cyst content is proteinaceous. That's why it's T1 hyperintense.
Yeah. What do you think that it is? Like, what is your differential?
Yeah, given the location and the appearance of the cyst, could be polymyxoid astrocytoma. Also could be epidermoid cyst. I don't think we have DWI, right? Diffusion.
No, but it does not restrict.
Yeah. Okay. Least likely arachnoid cyst, given the appearance and also the fluid contents on imaging. Less likely it could be ganglioma, given that it's mainly cystic and not solid tumor. Could be also least likely craniopharyngioma.
So the mnemonic for this, like paracellular lesions, is just the Satchmo thing. So like what you said, it could be dermoid, epidermoid, or craniopharyngioma, or Rathke's cleft cyst, and all these other things in the mnemonic here. And so for this patient, now that from the prior CT that he had back a few years ago, there wasn't as much compression on the brainstem, and now there's compression on the brainstem. He has more worsening vision problems. What would you do now?
Yeah, so for this lesion, given that it's causing progressive symptoms and also growth and size, it needs to be decompressed. Now, decompression is to achieve, first of all, what kind of lesion this is. If it's a tumor like polymyxoid astrocytoma, then that would dictate the amount of resection and the extent of resection. So I would definitely proceed with surgery for both diagnostic and also resection. It's too early to say radiation, given that I don't know what kind of cyst this is or lesion this is.
Yeah. Okay. And would you try to, for the extent of resection, would you try to, just take everything out, or just kind of see intraoperatively how it is, or plan for just like subtotal resection in the beginning?
Yeah. So gross total resection with this, given that it's in the cellular paracellular hypothalamic area, it's going to cause significant morbidity. So I would decompress the brainstem, given that there's significant pontine and also midbrain compression. So I would decompress that area first, and also the temporal lobe. So I would do maximally safe resection, but not gross total resection. I would preserve the stock and sacrifice it.
Okay, so what we ended up doing was a combined retrolab subtemporal approach, just because this lesion goes all the way from like posterior clinoid down to a little bit below the IAC. And so what we ended up doing was just to because this was ended up being a craniopharyngioma. And so the craniopharyngioma was really stuck to the optic nerves. And so we ended up leaving this cystic area supracellularly. And then it was also really adherent to all the vessels like PCA, SCA, basilar. And so we weren't able to get, mobilize that capsule off those vessels entirely. And so because we had a subtotal resection, we ended up leaving the stalk. And so we'll turn it over to Dr. Saad for the path.
Okay, so this is a craniopharyngioma, and that's what you see histologically. So there are two major components in craniopharyngioma. The first one is the squamous epithelium, and here you can appreciate very nicely. And then you have the wet keratin. So wet keratin is not necrotic keratin, it's a keratin that is devoid of its nuclei. So this is some keratin here, which is very well formed nucleus and cytoplasm. And here you can see that the cytoplasm is very large, pink, and it doesn't show any nucleus. So this is adamantinomatous craniopharyngioma. Adamantinomatous craniopharyngiomas are, this is a mistake here, sorry. So adamantinomatous craniopharyngiomas are positive for beta-catenin in a nuclear way. Beta-catenin will stain the intercellular bridges because beta-catenin is a component of the cell-cell adhesion system. So this is adamantinomatous craniopharyngioma.
And then let me just reshare my slides. Okay. So like Dr. Saad said, this is a craniopharyngioma. So they usually originate from the residual cells of Rathke's pouch, and then they're WHO grade 1. And so there's a bimodal age distribution. So usually in children, it's a adamantinomatous histology, and then for adults, it's a papillary histology. And so just a quick overview. So for adamantinomatous craniopharyngiomas, it's usually mutation is beta-catenin, and for papillary craniopharyngiomas, it's BRAF. And so this is important because the BRAF mutation means you have a chance of treating these papillary craniopharyngiomas with chemo. And so just based on MRI alone, you can actually diagnose these craniopharyngiomas and see if they're papillary versus adamantinomatous based on imaging characteristics alone. And so for these papillary ones, if they have 3 of the 5 features that are here, which is like if they're completely supracellular, if they're spherical, if they're predominantly solid or homogeneous enhancement pattern, then if they have 3 of these 5 features, then they're most likely papillary. And so for our patient, really had none of these. Ours was cystic, with both cellular and supracellular going into the middle fossa. And so it's most likely adamantinomatous. And so, as I was saying, that the MRI imaging is important because it can help to identify these pre-op. And so if they're papillary, then you can treat it medically with MEK and BRAF inhibitors, and they can show great response to chemo, like what you see here. Here they're giving these these BRAF inhibitors, and then you can see that it's showing good response here. And so I looked in the literature to see, whether for craniopharyngiomas, gross total or subtotal with radiation is better. And so for adults, found that gross total and subtotal resection with radiation have similar overall and progression-free survival and rates of recurrence. But then for children, this is also the same as well. For the pediatric population, it also gross total and subtotal resection with radiation have similar rates of tumor control. And so in adults, to answer the question of, if you should sacrifice a stalk, if you should do gross total versus subtotal resection, they say that if you're able to preserve the stalk and get some gross total resection, then that's the most ideal scenario. But, since craniopharyngiomas usually arise from the stalk, it's usually hard to preserve the stalk. So if you can get can can get gross total residual, then just go ahead and sacrifice the stock in order to get all that gross total residual. But if you can't, like in our case, then leave the stock. And so in pediatric patients, it was actually found that gross total resection, as expected, has higher rates of endocrinopathy than subtotal resection and radiation. So in these pediatric patients, it's actually because they're still growing and developing to prevent these endocrinopathy and hypothalamic dysfunction, subtotal resection plus radiation is actually preferred, but for adults, gross total resection is preferred when possible. So the second case, you can have, Victor, if he's on ticket. So this is a 21-year-old female with a history of headache, intermittent tingling in the right face for 3 months. No other significant past clinical history, neuro intact on exam. Here is the imaging. Victor, are you here? Okay. Or Sumed? Or Damien? Oh, it's Tyler.
Yeah, I'm here. Oh, did my computer? Oh no. Okay, cool. Sorry, I thought my computer froze again. So okay. So on CT, you can see there's a hypodensity on the right, like near the clinoid, that seems to exhibit some like heterogeneous contrast enhancement, and I guess that looks like, yeah, and some diffusion restriction. So I guess I would think like this bottom right is diffusion restriction. So I think maybe like epidermoid, dermoid, could be a meningioma. Would think like metastasis less likely.
This one is this one is actually T1, and this one's T1 with contrast. You see, this is
okay. Oh, I see. So it's not really contrast enhancing. Okay. Okay, but I still, based on like the diffusion restriction and like location, I would think like epidermoid, dermoid probably.
Okay, and then what is usually like bright on? So for like epidermoids,
Oh, like maybe like an aneurysm.
Or like what is usually like bright? What are the 5 things that are like bright on T1? Intrinsically.
So bone, no. Blood is one. Melanin. What else is there? Yeah, is it bone? No bone.
So yeah,
bone, right?
Fat, fat, melanin.
Oh, fat, right?
Proteinaceous stuff, and they usually say like heavy metals. So this thing is bright on T1, and then hyper intense on T2, and then on flare. This is a flare with fat saturation, and so you see here this is T1, and so you see all this fat in the
right. All the fat's bright.
It's bright, but here it's fat saturated. So here it's like it saturates with the fat suppressed sequence. And then here, a little bit of restriction, but not that much. And so differential, is like what you were saying, dermoid, epidermoid, or lipoma, or arachnoid cyst. And just to go over, so this is actually a dermoid, so dermoid cyst. They're on CT. It looks kind of like a lipoma, but instead a lipoma will be more like homogeneous signal intensity on this, CT with, and then for the dermoid cyst, it's more heterogeneous, like what you see here. And so for dermoid, because it's sebum, it's bright on T1, and then it's like heterogeneous looking like this. And then on this fat suppressed image, it'll suppress fat. It'll suppress on this this fat suppressed image. And so it's usually more located in the midline compared to epidermoid cysts, which are laterally in the CP angle. So then for epidermoid cyst, it follows actually CSF on all sequences, except it restricts diffusion. So this was what it will look like. But how you were saying for the epidermoid cyst, it's gonna, on like T1, it's gonna be, same as CSF, not bright. And then lipoma, as you can see here, it's like also, you know, fat intensity here, but it's just less heterogeneous compared to that dermoid, like you can see here and here. And then for arachnoid cyst, of course, you know, it follows CSF on all sequences. And so what we ended up doing was this Hakuba-Doling approach with a lumbar drain, and we did gross total resection, trying to remove the entire capsule, which we were able to do. And so we'll turn it over to Dr. Saad for the neuropath.
Okay, thank you. Okay, so this is the cyst at low magnification. So you can see the cyst lining. It is squamous epithelium overlying a dense fibrous tissue, and the cyst content basically consists of what we call keratin flakes. So the differential diagnosis here, as Dr. Wu mentioned, dermoid versus epidermoid. This is dermoid cyst because it has what we call skin adnexa. So here we have some sebaceous glands, and here there is a small hair shaft. So that's really the only difference histologically between a dermoid and epidermoid.
Let me share my screen. Okay, so you know, like Dr. Saad said, dermoid cyst, it has it's you know, it's a developmental anomaly with like ectodermal elements that are trapped in an enclosing neural tube. It secretes sebum, with like what I said earlier, which is why it gets that appearance on CT and MRI, and usually is in midline locations. And so found this table, you know, just a quick comparison of dermoids and epidermoids. And so it's called, so if you have a cyst that's lined just with stratified squamous epithelium and only containing keratin with desquamated epithelium, then it's an epidermoid. But when you have dermoid, it's the same as an epidermoid, plus you have hair and sebum due to these dermal appendages. And so usually dermoids are more common midline locations compared to epidermoids, which are laterally. And then epidermoids are usually isolated lesions versus dermoids are associated with other congenital anomalies. And so this is just to say, you know, what Dr. Saad was saying before, you know, these dermoids have these like adnexal structures, which have a hair and sebum. And so then this next case, 56-year-old female with left-sided lesion that underwent a resection of 80% at another hospital about 7 years ago. We don't have that imaging, but she now presents to us with a new MRI with worsening left facial numbness as well as pain, and imaging showing increase in size of lesion. So on exam, she only has left V1, V2, V3 distribution numbness, but otherwise she's intact. So here's the MRI. Is David here?
Yeah, I'm here. So you have a enhancing solid cystic mass lesion that's approaching Meckel's cave on the left side.
Mm-hmm.
Doesn't appear to be dural, and encroaching on the cavernous sinus as well on the side.
Yeah, and then it looks like it's going into foramen ovale as well here. And then, yeah, like what you were saying, it's like posterior cavernous sinus going into Meckel's cave right here. And then it's also iso-intense on T2. And so what do you think is the differential?
Yeah, I mean, extraocular mass lesion in this region, I would consider things like a trigeminal schwannoma would be top of my differential. Other considerations would be meningioma, as well. Could consider dermoid or epidermoid, but in this sort of case with these imaging findings, I wouldn't necessarily go down that route.
Mm-hmm. Yeah, so here's what I found. Actually, how they broke it down. There's like a, you know, neoplastic lesions, vascular, inflammatory, or miscellaneous lesions. And so, you know, if it's within the cavernous sinus versus, you know, if it's adjacent to the cavernous sinus, you have different differential diagnoses. And so with ours, you know, it's within origin within the cavernous sinus. So, you know, differentials are schwannoma, like you said, you know, neurofibroma, meningioma, hemangioparasitoma, you know, And so just to differentiate, because you had mentioned, schwannoma versus meningioma, the schwannoma, it's going to be this on the left. And so it's more like dumbbell shaped, and there's going to be like more cystic areas. And enhancement's going to be more heterogeneous, but then for meningioma, it's here on the right. And so it's going to be more homogeneously enhancing, like you see here. There's not going to be really a cystic component. There could be also a dural tail. And also do you remember like about the carotid, like what's important about the difference between a schwannoma and meningioma, and how you can differentiate it based on looking at the cavernous carotid?
I'm not entirely sure.
Yeah, so for the meningiomas, when they invade the cavernous sinus here, they get large and they can encase the carotid and cause narrowing of the carotid here, like you see here. Oh, and but then for like the cavernous sinus, because they're usually soft, they don't cause like narrowing, they just kind of push on the carotid. So you see here. And so, just going back to what we had discussed earlier with the dermoid cyst, this case was the prior case, it's in the same location. It looks pretty similar as, our case here, right? But on the opposite side. This is a dermoid cyst, not a trigeminal schwannoma, because, on this T1 without contrast, it's bright, which is characteristic of a dermoid cyst. But then for trigeminal schwannoma, it's going to be contrast enhancing, which dermoid cyst isn't. And so what would you do for this patient, now that it's grown, it's causing her symptoms? Would you observe radiosurgery, microsurgery?
Yeah, so in this case, with a recurrent lesion that's previously been resected partially, you said the patient hadn't gotten radiation, right?
It hasn't gotten radiation, no.
Yeah, I mean, and she's symptomatic. I would actually try to achieve a greater resection this time and then have adjuvant radiation afterwards.
Yeah, so we ended up doing is, because the patient, was already having symptoms, so we wouldn't really observe it. And they had actually referred to someone else for Gamma Knife, but they didn't want to do it because of the size. So they ended up referring to us for surgery. And so we ended up doing a modified cranial orbital approach with Hakuba Dolink and anterior clinoidectomy. And we were able to get gross total resection. And so we'll turn it to Dr. Saad for the pathology.
Thank you so much. Let's see. Okay, so I'm going to start showing you the schwannoma feature. So this is what we call, and you've heard us a lot at frozen section, it's a benign spindle cell neoplasm for obvious reasons. So the tumor cells are elongated or spindle shaped, embedded in a dense fibrous stroma, and no high-grade features. By high-grade features, I mean mitosis, necrosis, or vascular proliferation. And this is a not the best Verocay body that you can get, but this is good enough. So basically, you have palisaded nuclei at the periphery, and the center of the Verocay body consists of the cytoplasmic processes of the cells. So here, S100, and it confirms that it is indeed, this is a schwannoma. However, there are foci within the center of the schwannoma where the tumor cells start to become larger with prominent nucleoli, and also atypical mitosis. So this is the tripolar or Mercedes-Benz mitosis, which indicates almost all the time malignancy. And here you can see the significant atypia and the pleomorphism that stands out, if you compare them to the background schwannoma. So this is Ki67. The schwannoma labeling is almost 1%, very low. However, this focus that I showed you is picking up Ki67 in a significant way, and it's approaching 20-25%. So this is an example of low-grade malignant peripheral nerve sheath tumor arising within the schwannoma. The MPNST component was completely encased by schwannoma, so you can assume the margins of the MPNST are negative.
Okay, let me share my screen again. Okay, so yeah, so this MPNST, it was coined by the WHO to really replace names like malignant schwannoma, neurofibroma, neurogenic sarcoma, and malignant neurolimnoma. And so the incidence is, it's pretty rare. It's 0.01%, and then associated more with neurofibromatosis. And so you can actually have two different paths to get this MPNST. And so this primary is if it's de novo arising from a healthy peripheral nerve, and secondary is if it's arising from a pre-existing schwannoma or neurofibroma, and that can be either spontaneously or after radiation. And so in our case, because the patient didn't have any radiation, it was just spontaneous transformation from a schwannoma to a MPNST. And so radiologically, I thought it was, I had looked it up how to differentiate trigeminal schwannomas versus MPNST. And so, because one is, trigeminal schwannomas are benign versus MPNST, it's malignant. So it's important to try to be able to differentiate, preoperatively which one it is. Because the treatment is different. And so, they can look similar. They can both look dumbbell shaped, both contrast enhanced, both have cystic, a little bit of cystic component. But I thought the main actual feature that differentiates them is that for this trigeminal schwannoma, here on this first row, it's usually hyper intense on T2, but then for this MPNST, it's usually hypo or iso intense on T2, like you see here. And usually it's going to have more of an intratumoral cystic necrotic change component than compared to this one. And then it's going to have some like peritumoral edema, which you can see here. And then in this trigeminal schwannoma, you don't see. And of course, based on histology as well, like Dr. Assad was describing, and then the rapidity of growth. And so for MPNST, gross total resection or subtotal resection followed by radiation if you're not able to get it all is the treatment. And so the extent of resection is actually the most important factor that affects overall survival. And so if you are not able to get it all, there's actually high rate of recurrence and likelihood of like distant metastasis. And so, close follow-up and also cranial and spine imaging is needed versus trigeminal schwannoma, because it's benign, there's no risk of metastasis. You just need an MRI, not like an MRI of the spine. Then this last case is going to be a 39.
Just a comment on that last one, making that preoperative diagnosis is so critical in those cases. So a PET scan is actually one of the best ways to kind of differential between a malignant nerve sheath schwannoma versus a benign.
Mm-hmm.
And then, as you said, it changes your extent of resection. So going in there with a normal schwannoma, we're always taught that if it's stuck to the nerves or whatnot, you can leave it behind. But if it's malignant, you have to really plan a very careful approach to try to do a maximal resection to give that person the best chance. So it can really drastically change your surgical approach by knowing that preoperatively. And it's always good if you have suspicion to get the PET scan to make that decision.
Thank you. Thanks, Dr. Ivan. And so for the last case is going to be a 39-year-old male with left-sided tinnitus, decreased hearing, left facial numbness, left facial twitching, and tongue numbness, as well as inability to taste with the left side of the tongue. And has this is his exam here. And so here is the CT that we got. Is Adam on? Or is Sumedh on now? Or okay. Is Long there?
Hey, Ava, sorry, I'm here.
Okay. Can you describe what you see here?
Yeah.
So just if you can compare the left and right, like here.
Yeah, so it's like bone window axial CT. There appears to be erosion of the bone along the left skull base.
Like this part's missing, right? So this is the
Yeah.
Yeah, the like petrous
The
apex.
left petrous bone, yeah, the left petrous
And then here,
is extending into the clivus.
Mhm.
Um,
okay, and then I'll show you the MRI. And so this is the MRI. So this is a T1 without contrast. And then this is a T2. This is FLAIR with fat suppression. And then this is the DWI, and these are contrasted scans.
So looks like a T1 hyperintense non-diffusion restricting lesion along the left petrous face with mass effect on the pons. I would say like differential would include like dermoid cyst, epidermoid cyst, potentially like the cholesterol granuloma.
Mhm. Yeah, good. So like what you had said, you know, that's this is bright on T1, and on fat suppressed, it doesn't really suppress, and then it's hyper intense on this T2, and then doesn't contrast enhance. And so differential, you know, I found this differential for like petrous apex lesions, you know, so if it's non-enhancing, can be a cholesterol granuloma versus like a mucocele or encephalocele, and then if it's like enhancing, can be a meningioma or schwannoma. And there's actually a better, there was this algorithm I found, you know, if it destructs the bone or if it's just expanding it, and, you know, whether diffusion restricts or is bright on T1. And so for our case, you know, it's not diffusion restricting, it's bright on T1. So it's a cholesterol granuloma versus, you know, if it was not bright on T1, it's probably a encephalocele or, you know, a cephalocele or a mucocele. And then the main differential to differentiate, you know, cholesterol granuloma versus the main differential of a cholesterol granuloma is cholesteatoma. So you can see, you know, for the cholesterol granuloma, it does not diffusion restrict, and for the cholesteatoma, it does. And so what we ended up doing was a retrosig with marsupialization, you know, because the patient had symptoms, we tried to drain the cholesterol granuloma and marsupialized it to prevent recurrence. But you could also do an endonasal approach for open drainage and create a path into the sphenoid sinus to prevent it from recurring. And so we'll turn it over to Dr. Saad for the path.
Okay, so this is the lesion at low magnification. You can see some dense fibrous tissue and these spaces. These are areas where they show what we call hemosiderin deposition in the fibrous tissue, and also some multinucleated foreign body giant cell reaction. But more importantly is this focus here. So you have mononuclear inflammation, a little bit of hemosiderin-laden macrophages, and you have a lot of these elongated spaces. These spaces used to be cholesterol, which are empty now because of overnight processing in alcohol and formalin and so many other solutions. So this is an example of cholesterol granuloma.
So okay, so then like Dr. Saad said, this is a cholesterol granuloma. So it's the most common primary petrous apex lesion. You know, and really the cholesterol granuloma describes a granulomatous reaction to blood breakdown products, primarily cholesterol, and it usually arises in disease states where, you know, normally there's ventilated air, you know, spaces that are obstructed, like in chronic or acute otitis media. And so the main primary differential is this cholesteatoma, like I was saying before. And so here I found this table, you know, just to differentiate between cholesterol granuloma versus cholesteatoma. And it's important to make this distinction between them because, again, you know, the treatment is different for these two. And so a cholesteatoma is really just a cholesteatoma is basically an epidermoid within the middle ear, and they're both, you know, ectodermal cells in abnormal locations. Versus cholesterol granuloma, it's like from you know, from obstruction like chronic or acute otitis media. And so just on imaging, on CT, it's going to look similar. It's going to be this non-enhancing soft tissue mass in the petrous apex with variable bone erosion. But on MRI, you can distinguish it because for cholesterol granuloma, it's actually brighter on T1 due to all the lipids and protein and methemoglobin. And then for cholesteatoma, it's basically an epidermoid of the middle ear. So it's going to look like an epidermoid. It's going to follow CSF on all sequences except for diffusion restriction, like an epidermoid. And then for histology, it's going to be a cholesterol granuloma is going to be like what Dr. Saad had described with these cholesterol clefts. It's going to have some, lipids, hemosiderin-laden macrophages and giant cells surrounding it. And then for cholesteatoma, it looks like an epidermal, it's an epidermoid, so it's going to look like what an epidermoid histology looks like, which is just stratified squamous epithelium. And so what's important is, it's important to differentiate the two, cholesteatoma versus cholesterol granuloma, because the treatment is different. So for a cholesterol granuloma, because it's just a fibrous capsule without a true epithelial lining, complete resection is not necessary. And so the treatment is just surgical drainage and permanent aeration to prevent recurrence, versus for a epidermoid and a cholesteatoma, you have to resect the whole thing, including the capsule, or else it's going to recur. And so I think that's the end.
Okay, thank you, everyone.